Welcome to this new Gentian webinar in our Calprotectin webinar series. My name is Paula Lindner and I'm the product manager for GCAL, the Gentian Calprotectin Immunoassay. Today I'm excited to talk about the use of Calprotectin as biomarker in rheumatoid arthritis. I want to start to give you a small introduction and background information about the protein Calprotectin and the link to the inflammation in rheumatoid arthritis. Calprotectin belongs to the S100 family of proteins, a superfamily of calcium-binding proteins, which are essential components of the immune response. Calprotectin is a heterodimeric complex of two S100 proteins, S100A8 and A9. Synonyms for the heterodimer calprotectin you will also hear regularly are S100A8 and A9, myeloid-related protein MRP814, granulin A and B, and its original name on its first isolation from Fagerhol and colleagues in 1980 was major leukocyte protein L1. Calprotectin is mainly expressed by phagocytes like neutrophils, monocytes, and macrophages, and makes up a large proportion of the cytosolic proteins in these cells. Calprotectin is a key alarmin released in the first-line immune defense as a response to infections and non-infectious inflammation. Its antimicrobial activity is mediated by the sequestration of zinc and manganese from the bacteria environment, thereby starving the pathogens. Calprotectin is also a pro-inflammatory transmitter, mainly by binding to two receptors, RAGE and the toll-like receptor 4, driving the procession of inflammation. Due to its fast and direct upregulation in the inflammation reaction, calprotectin has been shown to be a valuable biomarker in a whole range of inflammatory conditions, including bacterial infection, sepsis, and lately also in severe COVID-19, but also in non-infectious inflammatory conditions, including autoimmune diseases and rheumatoid arthritis. Let us now take a short closer look on the link of calprotectin to rheumatoid arthritis. Rheumatoid arthritis, RA, is a progressive autoimmune disease leading to inflammation in the joints, characterized by elevated inflammatory cytokines, synovial inflammation, and destruction of joint cartilage and bone erosion. In RA, phagocytes, including macrophages and neutrophils, are abnormally activated and accumulated in the synovial tissue and synovial fluid, initiating production and release of multiple inflammatory factors, such as calprotectin, and irreversible joint destruction. Calprotectin, with its pro-inflammatory functions, is described to drive inflammation in RA by amplifying the production of inflammatory markers by phagocytes, induce production of cytokines like TNF-alpha and IL-6, and attracting more phagocytes to the joints, leading to an enhanced feedback loop, accumulating even more calprotectin at the inflammation site. Early diagnosis is of particular interest in this potentially aggressive disease to prevent joint deformity and functional impairment. A biomarker reflecting the amount of inflammation and joint destruction would aid RA prognosis and be clinically helpful in optimizing individualized medical treatment decisions. Since calprotectin is released in the inflammation in the joints, it is also an interesting candidate to monitor the inflammation activity in RA patients. Going directly to the site of inflammation, many studies have found high calprotectin concentrations in synovial fluid obtained from the joints of rheumatoid arthritis patients. And since its low molecular weight allows calprotectin to enter the systemic circulation, it can be measured in the blood, where it directly reflects the inflammation in the synovium. There are many clinical studies showing the value of calprotectin as biomarker. Calprotectin has been shown to correlate with disease activity, as well as the degrees of inflammation under effective treatment. Calprotectin correlates with the rheumatoid factor or RF and many clinical scores, like disease activity score at 28 joints, swollen joint counts, the Simplified Disease Activity Index, Clinical Disease Activity Index, the SHARP score, and also the Rheumatoid Arthritis Articular Damage score. In addition, it has been reported that calprotectin correlates also with other inflammation markers typically used in RA diagnostics, like erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. However, it has also been reported that calprotectin can be a superior inflammation marker compared to ESR and CRP. Now I would like to present some selected publications from the large amount of scientific results published related to the use of calprotectin as inflammation marker in rheumatoid arthritis. First of all, it's important to mention that multiple studies have shown that calprotectin is associated with clinical scores for RA activity and joint damage. I want to highlight the meta-analysis from Bay and colleagues in 2017 that analyzed 16 studies, including over 800 RA patients, and evaluated the relationship between calprotectin levels and rheumatoid arthritis, and the correlation between plasma serum calprotectin and RA activity. Throughout the study, they found calprotectin levels were significantly higher in the RA group than in the control group, significantly elevated in the RF-positive RA group compared to that of the RF-negative RA group, and they found significant positive correlation between calprotectin levels and CRP or DS28 clinical score. So in conclusion, the author summarized that the calprotectin levels correlated with disease activity, and calprotectin plays a key role in the inflammation in RA. The table below shows an exemplary result from Hammer and colleagues reporting consistent association between calprotectin and the two measures of joint damage, the modified Sharp score and the RAD score, where calprotectin was the only inflammation marker independently associated with clinical scores in the multivariate analysis. Next, I want to highlight that calprotectin levels also correlate with disease severity and activity. In this study, the authors evaluated how calprotectin can stratify disease activity in RA patients receiving tumor necrosis factor inhibitor treatment. Calprotectin levels were significantly lower in patients in clinical remission compared with those with low disease activity, and also showed a stepwise increase with disease severity for all analyzed clinical scores. In addition, the authors also found that calprotectin levels correlated better with all activity in disease than CRP and ESR, and only calprotectin was able to distinguish between remission and low disease activity across all clinical scores. This last important point, that calprotectin can even distinguish between patients in remission and patients with subclinical low-grade inflammation activity, was also confirmed in a study from Honakowa and colleagues. In some patients in clinical remission, low-grade inflammatory activity may persist but remain undetectable by routine clinical examinations and laboratory tests, and might only be visualized by ultrasound. The authors showed that calprotectin has the capacity to distinguish between patients in ultrasound-defined remission and those with residual ultrasound subclinical inflammation, while CRP was not able to distinguish these patient groups. As you see in these two figures comparing the levels of patients in remission with subclinical activity, and the ROC analysis showing calprotectin can distinguish between remission and subclinical activity. Another important feature of calprotectin is that it can be used to assess disease activity also under treatment inhibiting inflammatory proteins. In this study from Yarber and colleagues from 2020, it was also shown that calprotectin correlates with disease activity in RA patients receiving IL-6 inhibitor treatment, while CRP levels were influenced by the treatment and did not reflect the true inflammation status of the patient, seen both by assessing the DAS28 ESR score and the swollen joint count in RA patients. In line with the correlation with disease activity, there are reports showing that calprotectin can be used to directly monitor the treatment response. To the left, you see results from a study of Choi and colleagues analyzing the calprotectin levels to monitor the response to biological treatments. They could show that patients responding to the treatment with TNF-alpha inhibitors had decreasing calprotectin levels over time, while non-responders had unchanged calprotectin levels. Similar results not shown here were also reported for 2 additional agents, namely infliximab and rituximab. To the right, you see results from a study of Andres and colleagues in recent onset RA patients under conventional treatment, where again the calprotectin levels decreased after successful medication and normalized within 3 months after treatment. In addition, monitoring calprotectin can even predict the relapse of patients under treatment, as shown in this study, where high baseline calprotectin levels predicted relapse of patients in remission or low disease activity with high sensitivity and specificity, as you see in this table. And the Kaplan-Meier curve illustrates the predictive performance of high calprotectin levels, clearly showing the decrease in survival. And to the right, you can also see that calprotectin levels increase in relapsed patients, in line with the previous studies showing that calprotectin levels correlate with disease activity. Finally, I want to highlight one more important value of calprotectin as inflammation biomarker in RA compared to the classically used acute phase inflammation biomarker CRP and ESR. More than 40% of patients actually have normal CRP and ESR levels despite active disease, and therefore calprotectin is a superior inflammation marker in these patients. It has been shown that calprotectin can discriminate between RA patients and healthy controls and low versus high disease activity, also in patients with normal low CRP levels. And as I've already partly shown in the slides before, there are studies directly comparing the performance of calprotectin and CRP and ESR, showing that calprotectin levels correlate strong with disease activity and treatment response, and can distinguish better between remission and low disease activity, in contrast to CRP and ESR. So in summary, we have today talked about calprotectin in rheumatoid arthritis as a sensitive inflammation marker which correlates with disease activity, measured in multiple studies using several different assays and comparing the correlation to several clinical scores. Calprotectin can be used to monitor treatment response and monitor and predict relapse in patients under biological treatment. And importantly, calprotectin can be used to assess disease activity even when CRP and ESR are low in RA patients. Finally, I would like to highlight the automated turbidimetric calprotectin assay, which is available from Gentian. Gentian's calprotectin immunoassay, called GCAL, is a turbidimetric assay specialized for calprotectin testing in serum and plasma samples with dedicated reference ranges and specifications. It is rapidly performed in only 10 minutes with ready-to-use reagents, and since it's an open channel assay, it can be applied to a wide range of clinical analyzers and thereby be integrated in the installed instrument base at your laboratory. It is CE marked, so it's available for diagnostic use in serum and plasma to provide fast information about the patient's inflammatory status to the clinicians. Thank you very much for your attention. You will find more information and insight about calprotectin and the GCAL assay on our website, and please feel free to reach out to us per email as well.